everyone. Welcome. Happy Friday. It is going to be a wonderful morning. Well, it's morning where I am, probably afternoon where you are, of learning about test taking strategies. So today is Rapid 30, and we will be going through some QBank questions. So just a few housekeeping things before we get started. If you've never joined us before, and you have a question and you're joining me on Zoom, please don't hesitate. Go ahead and put that question in the Q&A so I can answer that for you. If you have a general comment or you are just answering the question, please go ahead and put that in the chat for me. So without further ado, go ahead, let me know in the chat who is excited to be here. Who is excited? Anybody loves some good test questions? I'm really excited about today's version because we are going to be going through OB questions. Now, I am Jennifer Bonner. I'm a certified nurse midwife. I have 5 years experience as a midwife. I have over 15 as a nurse, and this is what I love. I love OB questions. It is one of my very favorite things. So, anybody love OB? Anybody excited about OB? Okay, super excited. Yes, we have some OB nurses. All right. So, regardless, if you're in nursing school or maybe you're preparing for the NCLEX, going through test questions is going to be really important. It's going to give you the opportunity to practice what types of things you are most likely going to see on the NCLEX. So, as you take questions, you start to get accustomed to how those are worded, and we'll talk through some test taking tips along the way. So, let me show you how to go ahead and get into that. So what you're going to do is you are going to go into your QBank, create test, and I usually go with mixed. I'm going to do subject or system. I'm going to so I would typically use your unused questions. I'm going to use all because I've used quite a few of them. And we're going to allot for 15. We'll see if we can get through those. We'll probably get to 10 or less. So, and then you hit next. And then I can go through and click what I am interested in. So we are going to do maternal and newborn health. Next. And let's do antepartum. Create test. Okay, someone was asking if I can explain what's included in our 2-hour NCLEX course. So this is a very much abbreviated NCLEX review where we are going through some high yield content on various different areas. So we go through just kind of hitting the highlights of fundamentals, some of the specialties, mental health, pediatrics, that type of thing. Great question. All right, so let's go ahead and check out this question together. So the nurse in the emergency department is caring for a pregnant client. So at 07:35, the client reports sudden onset of nausea and vomiting, heavy vaginal bleeding with dark red blood, frequent low intensity contractions, lower abdominal pain rated 9 out of 10 on the numerical rating scale for the past 2 hours, and lower back pain rated 2 out of 10 on the numerical scale for the past 24 hours. She is 30 weeks pregnant. She's a G4, T3, P0, A0, L3, and she's RH positive. Vital signs, temp of 99.8, a pulse of 99, respiration 16, blood pressure 112/76, and a pulse ox reading of 94% on room air. Uterine tenderness is present with gentle palpation. The client states they are a 1 pack per day smoker and deny any alcohol or illicit drug use. Okay, so in this situation, what are my key concerns here? What red flags are you seeing? Okay, so yes, she is pregnant. So let me get my trusty dusty pen. So she is 30 weeks pregnant. Yes, she's bleeding and it is dark red. So we're not looking for a condition yet. We're just looking at those red flags. So she's a smoker. She has pain, that 9 out of 10. Abdominal pain, but she also has lower back pain. Okay, she has uterine tenderness. You got it. Here it is, uterine tenderness. Okay, her temp is okay. I mean, it's kind of a low grade. It was sudden onset. She has nausea and vomiting. Why do we think she might have nausea and vomiting? Maybe because of the pain, possibly. Yep. And that pain, that bleeding is heavy. Okay. So let's see. So she had an sudden onset of that nausea, vomiting, heavy vaginal bleeding that's dark red. She is having frequent contractions. She has that lower abdominal pain, low back pain. She's 30 weeks pregnant, uterine tenderness. Okay, she's smoking cigarettes, but no alcohol or illicit drug use. Excellent job. Okay, let's go ahead and clear those. Now, what we're going to do here is we are reviewing that data and we're going to drag from our choices to specify what condition she's most likely experiencing and 2 actions. What do we think? So many of you are saying placental abruption. Okay, so let's drag placental abruption up here. Whoops. Let me make this a little bit bigger so we can drag and drop as we need to. Placental abruption. All right. So what actions are we going to take? Are we going to initiate fetal monitoring, administer Rh immunoglobulin, assess for signs of hyperemesis, start peripheral access, or perform an ultrasound? What do we think? Okay, so I'm seeing a lot of you say, let's start some fetal monitoring. So let's move that up here. What else? Some said ultrasound, some said peripheral access. Ooh. All right. It looks like ultrasound is winning. Oh, nope, it's peripheral access that's winning. Okay. So let's move peripheral access up here. All right, so what are we going to monitor? Are we going to monitor the fetal monitor, the 24-hour urine, strict INOs, vital signs, or serum creatinine? What do you think? What are we going to monitor here? Okay, so many of you are saying fetal monitoring, so let's move that one up. Whoops. Okay, and many of you are saying vital signs, so let's move that one. All right. So we think she has fetal placental abruption. And we need to get her on a fetal monitor, start some IVs, continuous monitoring, and vital signs. All right. So we are going to go ahead and move forward, and we did it. Okay, so let's look at this. Why would it not have been placenta previa? What are the key things in there that lets me know it's not placenta previa? What do you think? Because she's having pain. Placenta previa is painless, bright red bleeding. Very good. How do we know it's not preterm labor? Why do we think it's not preterm labor? So she's having those contractions. She is 30 weeks, which is preterm because of the bleeding and that amount of pain, right? So it is a pain of 9 out of 10 for the last 2 hours. It doesn't sound like it's coming and going, and she's having that heavy vaginal bleeding. You got it. Now, why do we not think it's preeclampsia? What am I looking for with preeclampsia? Her blood pressure. So her blood pressure right here, let me get my pen out. Her blood pressure is 112 over 76. That is normal. That is just fine. I'm not concerned about her blood pressure. So does everybody understand how we got to this answer choice? Nice work. Way to go. All right, let's look at our next question. The nurse is caring for a pregnant client with placenta previa. While administering oxygen and starting an IV infusion, the client becomes anxious and asks the nurse, "What's happening?" The nurse says not to worry and that everything is under control. What is the best description of the nurse's response? This is an incorrect response, as the healthcare provider should be the one to offer information and assurance. The response is inadequate, as the client has the right to understand the type of treatment being received and the reason for the treatment. The response is effective, as the reply serves to lower the client's anxiety. Or this response is adequate, as the nurse's actions are routine, following orders of the healthcare provider, and therefore require no explanation. Let me know in the chat. What do you think? All right, I'm seeing some back and forth between A and B, but it looks like B is the winner. This response is inadequate, as the client has the right to understand the type of treatment being received and the reason for the treatment. Let's see what our answer is. We're absolutely right. Okay, so for those of you that chose letter A, so tell me, what is wrong with what the nurse said? She said, not to worry, everything is under control. So what have we just done there? We have diminished her thought process. Don't worry, there's everything is fine, right? So one of the rights within that American Hospital Association Clients Bill of Rights is they have the right to, and they're encouraged to find out the information that they need about their diagnosis, their treatment, and their prognosis. So we can get rid of letter A. This response is effective, as the reply serves to lower the client's anxiety, but it is not a appropriate response. We have diminished her feelings. And letter D, the response is adequate, as the nurse's actions are routine, follow the orders of the healthcare provider, and require no explanation. Yes, we are carrying out what we need to do, right? We're helping our client, we're making sure she gets the care she needs, but these are not routine procedures, right? So we need to make sure that we're explaining what we're doing and make sure that our client is safe. Okay. So when we are explaining what we're doing, our client can better understand, and that will hopefully decrease her anxiety. We want to be truthful with what we're doing. All right, let's check out our next question. So, no, we didn't say everything is fine, but the nurse said not to worry. So, don't worry, right? Don't worry. All is well. Everything is under control. So that's where I was getting at. Thank you for that that clarifying question. All right, so the nurse cares for a pregnant client with a history of cholestasis. They're presenting to the emergency department complaining of severe itching, particularly in the palms of the hands and the soles of the feet. The nurse anticipates which of the following clinical manifestations associated with cholestasis: jaundice, hypotension, hyperglycemia, or bradycardia. So if you could rephrase this question, how would you do that? How would you rephrase this question? So many of you are saying, what are the signs and symptoms of cholestasis? Okay. So I'm seeing a lot of A's. I'm seeing some C's. Seeing some A's. I'm seeing some C's. Okay. So many of you are saying letter C. So if I was going to rephrase this question, I would say, what um what signs and symptoms am I going to see with cholestasis in pregnancy? So we know that she is already itching on the palms of her hands and the soles of her feet. What else am I going to see? And you're saying letter C, hyperglycemia. Whoops. All right, so we're moving on to the next one. So the next part, that 16-year-old female client. Whoops. Sorry, we didn't reveal that answer. Oh, it's letter A. Okay, let's see, where was the breakdown here? So why would it not be hyperglycemia? So that's not typically something that we see with cholestasis. Now, normally it's going to primarily affect the liver, right? Its ability to process bile, but it's not directly affecting that glucose. Let's look at letter B. So hypotension is not typically associated with cholestasis. Remember, it's mostly affecting that liver. That's the majority of what we're going to see. So here we're going to look at which one of these would most likely involve the liver, and that is jaundice, letter A. Nice work. All right, we're headed into an NGN question. These are one of my favorites. So let's take a look at this one. So at 10:40, a 16-year-old G1P0 at 35 weeks gestation reports a frontal headache and edema in the hands and face that started 3 days ago. Despite taking acetaminophen, she reports that the headache has not subsided. She rates her headache pain as a 7 on a scale of 0 to 10, and the headache is getting so bad that she reports photophobia. She denies any abdominal pain, nausea, vomiting. She reports missing her last two antepartum checkups because of the lack of transportation. Her vital signs: temp of 97.7, pulse of 95, respirations 19, blood pressure 141 over 92, pulse ox of 95 on room air. Her dipstick shows proteinuria. Dipstick, we went ahead and analyzed it. It showed proteinuria. We have fetal heart rates through a Doppler of 134. We have vital signs. That blood pressure is 144 over 94. She's 96% on room air. And then we go ahead and get an ultrasound. So, what are our key red flags here? What are those big red flags that we're seeing? Let me know in the chat. She has proteinuria. Yep. She has a frontal headache. Edema. So not only edema, but it's in her hands and face. Okay. She took acetaminophen. It didn't help. She has photophobia. Her blood pressure. Her blood pressure again, and her blood pressure again. Yeah, you got it. And it's not relieved by that acetaminophen. You got it. So let's go ahead and see what our orders are. So we get some physician orders, get vital signs every 2 to 4 hours, obtain fetal heart rate, transabdominal ultrasound, obtain medical records from previous visits. Okay, so when we go over to our question, it says for each assessment finding, click to specify if the finding is consistent with the disease process of preeclampsia, severe preeclampsia, or eclampsia. Now, these might apply to more than one. So let's look at that blood pressure of 143 over 91. Which one does this most likely come with? Preeclampsia, severe preeclampsia, or eclampsia? Okay, I'm seeing preeclampsia. Okay, let's look at proteinuria. Which one does that go with? Preeclampsia, severe preeclampsia, eclampsia? Okay, I'm seeing lots of all. Very nice. No abdominal pain. Which one of these has no abdominal pain? Okay, I'm seeing lots of preeclampsia. What about facial edema? Which includes facial edema? Okay, seeing lots of all. Frontal headache. Frontal headache. Okay, I'm seeing all three. What about photophobia? Which one would include photophobia? What do you think? Okay, I'm seeing severe and eclampsia. Okay. So if this is one that you're struggling with, here's a good tip that I have for you. So what I would do is I would take where are they? My little stack of handy dandy little sticky notes, and I would write preeclampsia, severe preeclampsia, and eclampsia, and then I would write the different assessment findings and see if I can match them up. Anybody have small children, maybe grandkids in your home that are there, and you're maybe struggling with, man, I really want to spend some time with them, but I really need to study, and you're not sure how to do both? This is an excellent way to do that because we make it a game for them, but it's also a game for us. And then we say, hey, can you check and see if I got them right? So let's see how many I can do. And then they can cheer you on and then they can test your knowledge afterwards. All right, let's go ahead and see how we did here. All right, we actually did really well. Look at that. So yes, a blood pressure of 143 over 91 is preeclampsia. Proteinuria, we're going to see with all three. No abdominal pain is only with preeclampsia. Okay, no abdominal pain. Facial edema, all three. Frontal headache, all three. Photophobia is just severe preeclampsia and eclampsia. Now, somebody let me know quickly in the chat, what is the main difference between preeclampsia and eclampsia? What is the main difference? Yes, seizures. So when I say eclampsia, I think seizures. Very good. And so when you scroll down here, it's going to tell you what's the difference between preeclampsia, severe preeclampsia. So severe preeclampsia is going to have a systolic blood pressure that is 160 or greater and a diastolic of 110 or greater on at least two occasions. Now, this is key when we are diagnosing, when I'm in the clinic and I'm trying to figure out, does my client have preeclampsia? What's going on? I need two different blood pressure readings if they are elevated within 4 hours. So it has to be 4 hour increments. So if they come in at 8 o'clock in the morning, I'm going to check another one at least by 12. So if the second one at 12 o'clock is elevated and they have all those other symptoms, then that counts. Very good. Let's check out one more question before we go. The nurse receives a client's antepartum non-stress test result. Oh, excuse me. Reviews a client's antepartum non-stress test result as reactive. This finding is interpreted as what? A fetal heart rate acceleration less than 15 beats per minute, lasting less than 15 seconds. No late decelerations of the fetal heart rate. Late decelerations are present with a minimum of 50% of contractions or two or more fetal heart rate accelerations within a 20-minute period. I'm seeing A, I'm seeing D. Okay, I'm seeing a lot of A. All right, let's go ahead and check out our answer. Oh no, what's wrong? A fetal heart rate acceleration less than 15 beats per minute or lasting less than 15 seconds. So what are we looking at for a non-stress test to be reactive? We are looking for at least two fetal heart rate accelerations within that 20-minute period. And to be considered a fetal heart rate acceleration, it needs to go up for at least 15 beats and last for at least 15 seconds before it goes back down to normal. So letter A is out. No late decelerations of the fetal heart rate. So when we are looking at a non-stress test, no late decelerations, that would be a negative that would be a negative contraction stress test. That's what we're looking for in those. Late decelerations are present with a minimum of 50% of contractions. That is a no-go. We don't want to see that. That's a positive contraction stress test. But two or more fetal heart rate accelerations within a 20-minute period gives us a not a reactive non-stress test. Very good. All right. So did you struggle with some of these questions? Well, we have a code for you if you want to use it for just being a part of our webinar community, being present today. You can use I Love Archer for your purchases on our website, but I also have another surprise. So coming up on June 28th, that's tomorrow from 5 p.m. to 6 p.m. Central Time, I'll be hosting Bright Beginnings OB Nursing Essentials. This is where we're going to break down what you need to know for OB nursing. It is a $25 webinar. It's an hour long. We're going to go through the big concepts in the OB world. So you can use your smart device. Go ahead and scan that QR code there. That will get you right to where you need to be in order to register for that. And I hope to see you there. So regardless of where you are on your nursing journey, we have a place for you here at Archer Review. Whether you're getting ready to go into nursing school, you're thinking about nursing school, maybe you're in the thick of it. You are in nursing school and you're like, Jennifer, I'm going to pull my hair out. We have a community for you. If you're getting ready to take the NCLEX, if you are getting ready to take your nurse practitioner boards, we have a community for you. So go ahead, scan those QR codes, check out what the buzz is all about. We are incredibly thankful to have you joining us today on our webinar. We can't wait to see you back on Monday. I hope to see some of you this weekend at our webinar on OB nursing. Thank you for being a part of the Archer Review family, and we'll see you next week. Take care, everyone.